Hi everyone, welcome to today's session. I'm just going to give it another minute to see if anyone else joins and then we'll get going. Great, we'll get started. So welcome everyone to today's drop-in session on endocrine. So we have completed OTC, genitourinary immunity and malignancy, GI and respiratory, cardiology, and today we're covering endocrine. You should have hopefully watched the video that we've recorded and uploaded, and this is your opportunity to ask any questions as we go along. So I am Katie. I did the session for recorded the session for endocrine. And we're going to be talking today, going through some key slides as well as a bonus question as well. So before we get started, just a little bit about Pharmacy Foundations. So we help the development of pharmacists at all stages, and we do lots of different work, not just this pre-reg trainee pharmacist course. We do work with undergraduates, including work-based learning and clinical simulations, and then the course that you guys are on, so the foundation year supports the online revision course, and we do a mock exam, as well as the podcast. And then postgraduate, we do CPD events, networking opportunities, and clinical simulations. And we're affiliated with lots of different universities and professional bodies. So this is what we did last year. We did GP, clinical simulation, and curriculum implementation. So you can see we've got a dummy version of System 1 up there. We did some VR learning of a hospital. And now we're starting to do face-to-face sessions again, now that we are back in on campus and things for undergraduates and postgraduates. So this is the team. So we have a staff from a variety of clinical backgrounds and professional backgrounds, and we try and always bring you accurate and relevant content that's up to date. And one of the things we pride ourselves on is we have a certain proportion of our colleagues who have recently sat the GPHC registration assessment. So the advice that we provide you is up to date. And today's session will be led by myself. I'm Katie, and I am a respiratory and cystic fibrosis pharmacist working at Sheffield Teaching Hospitals. But prior to that, I was a foundation pharmacist, and I rotated through lots of different sites, doing lots of different clinical areas, including diabetes and endocrine, which is what we're going to be talking about today. And then before that, I was a pre-reg pharmacist in GP and hospital. So I've got a bit of experience of different sectors, but now I work in hospital pharmacy. Don't forget to follow us on Instagram, Facebook, and Twitter. I particularly like the Instagram page. I still do it now, still do the questions, still have a go at sort of spotting the errors. We do prescriptions where you can spot the errors, kind of multiple choice questions on the stories. And it's really good just for like on the go learning, just to keep your brain ticking over. And as I say, I still do it now, even though I've passed my exam. I'm qualified. And we have a WhatsApp support group as well. So if you want to join that, just scan the code and that'll take you to the WhatsApp group that's for you guys and your peers. That's kind of, it's all for you guys. It's a valuable avenue. You can share your thoughts, you can share resources, you can share questions, kind of as in asking each other questions. And these people will hopefully be able to help. So as I said, today's session is a drop-in session for any questions you guys have about endocrine and the session that we covered on the webinar. So unfortunately, the slider is not working today. So if you just want to pop the questions in the chat, if you don't want everyone to know, you can just directly message them to me, or you can put them for everyone to see, and we'll revisit those questions at the end and try and answer them. So a layout of today's session, we want you to put the questions in the chat. We're going to do some of your emailed questions that have been answered. I'm going to go through some popular sections again. So the key points from diabetes and a bit about endocrine as well. We've got a bonus multiple choice question. And then at the end, we're going to come back and revisit the chat to make sure that we've answered any questions you guys have got. Could someone just drop a message in the chat just to make sure I can see that you guys are here? just so I know that you're brilliant. Thank you. Fab. So our first question that some of you guys have asked is about, in the diabetes guideline slides, it says not to use dapagliflozin with pioglitazone. And why is that? So I did this session last week for some of our Bradford students, or Bradford graduates, and this was one of the questions that came up from them. And at the time, I couldn't find the answer because clinically, there's nothing that contraindicates them using them together. But it is in the guidelines that we don't use them. And that's basically because when the NICE committee reviewed them, they just excluded it from their discussions. So it looks like in the other SGLT2s, they compared the use of pioglitazone with other controls. And they said that the cost is pretty much equal and leads to a similar quality of life. So there's no direct interaction, but in the guidelines, it does say don't use dapagliflozin with pioglitazone. And it's also because not that many people are on pioglitazone. I don't know how many people you actually see dispensed kind of pioglitazone. It's not that common because there are lots of MHRA alerts and contraindications. So it's not something we see that much. So that's probably another reason as well. And the next question was about something we didn't really cover in the slide. So we didn't really talk that much about HRT, other than we did a multiple choice question about when you use estrogen and when you use progesterone and when you use them together. So the risks of HRT. Before I answer this, does anyone want to pop them in the chat if they know what they are? Any risks of HRT? If you were going to counsel a patient, if they were saying, I'm thinking about HRT, can you talk about the risks? What would you say they are? If you want to pop your ideas in the chat. So Althea said osteoporosis. Yeah, because of that, osteoporosis is a risk of menopause, isn't it? So we're going to hopefully resolve osteoporosis. And somebody said cervical cancer and breast cancer. Yeah, brilliant. So breast cancer, all types of systemic HRT increase the risk of breast cancer after 1 year of use. So when I say all types, I mean all oral or transdermal of systemic HRT. So you've got to remember that there's local acting HRT and systemic HRT. So systemic HRT increased the risk of breast cancer after 1 year of use. And the risk is higher for combined estrogen, progesterone, HRT, particularly for continuous preparations where you don't have any time off. But it is irrespective of the type of estrogen or progesterone. And again, the longer the duration of HRT, the further increased risk. So we say that the risk of breast cancer is lower after stopping HRT, but the risk persists for more than 10 years. So it's quite a long time after a patient's had been taking HRT for the risk to persist. And vaginal preparations containing low doses of estrogen to treat local symptoms are not thought to affect breast cancer risk, but patients may still want to avoid it for that reason. And we've said cervical cancer as well. So we've got, I think you might mean endometrial cancer. So that increased depends on the dose and the duration of the estrogen-only HRT. So in women with a uterus, the addition of a progestogen cyclically reduces the additional risk of endometrial cancer. So that's why for patients who haven't had a hysterectomy, so haven't had their uterus removed, we always give progestogen alongside the estrogen to help increase the risk of decrease the risk, of endometrial cancer. And the risk of endometrial cancer in women who have not used HRT increases with BMI. And the increased risk of endometrial cancer in users of estrogen-only HRT or TIB alone is more apparent in women who are not overweight. Another cancer that the increased risk of is ovarian cancer, but this is a smaller risk. And the excess risk disappears within a few years of stopping. And then someone else said clots, which is another risk. So using combined or estrogen only HRT. So as I've said, estrogen only not recommended if they've got a uterus. There are increased risk of DBT and PE, especially in the first year of use. In women who have predisposing factors, so personal family history, obesity, trauma, or bed rest, it's prudent to review the need for HRT, as in some cases the risks may exceed the benefits. So the point where I've seen this discussed in hospital is in a patient who had had a new MI and wanted to continue her HRT. And we explained that obviously she was at increased risk of clots. She'd just had a myocardial infarction, which is, is essentially a clot, isn't it? And she might be at increased risk because of that. So, but she said that if she didn't have a HRT, she felt like she would kill herself because that she needs it so much to help manage those symptoms of menopause. So in her, the risk-benefit decision was to continue the HRT for her mental health. But that's kind of the discussion that needs to be had with the patient, and she needed to be fully aware of the risk so she could make that decision. And alongside, we've got the risk of VTE, we've got risk of stroke as well. So as we know, risk of stroke increases with age. So older women naturally have a greater absolute risk of stroke, and combined HRT or estrogen only HRT also slightly increases the risk of stroke. HRT does not prevent coronary heart disease and should not be prescribed for this purpose. And there is an increased risk of coronary heart disease in women who start combined HRT more than 10 years after the menopause. So if they've had the menopause and it's been 10 years, then they're at an increased risk of having coronary heart disease if they start HRT. Hopefully that makes sense, and that's answered that question. So we're going to cover some of the key points of the slides. If you have any questions for anything that we've covered in this session, feel free to pop them in the chat and we'll come back to them at the end. So, also known as insulin-dependent diabetes mellitus is type 1 diabetes, whereby the pancreas produces, little or no insulin. And as I said before, the insulin-dependent term is sort of gone out of fashion. We don't really use that so much anymore because, as you'll know from the session, we do use insulin in type 2 diabetes as well. So insulin-dependent diabetes mellitus is a bit of a, not so much a favoured term anymore, but it is true that type 1 diabetes patients are insulin dependent, and it's an autoimmune disease that usually develops in childhood. So most of the time we see this developing in children and young people, but it can happen in later life. And as patients get older, it's harder to differentiate between whether it's type 2 or type 1. So we often do insulin antibodies to see kind of if it is type 1 or type 2, but those results take a few days to come back. And if in doubt, as I said, I think I said it last week actually, sorry, I'm getting muddled. If in doubt, a patient presents with high blood sugar and you're not sure if it's type 1 or type 2, we should always give insulin, because you can't, I'm not going to say you can't go wrong, but if you're not sure and you're giving somebody metformin and they've got type 1 diabetes, obviously we do use metformin in type 1 diabetes sometimes, but it's not going to bring the blood sugar down in the same way that insulin is. So if we have patients who are admitted and they start on steroids and the blood sugar goes up, we give them Humalog regardless of whether they've got type 1, type 2 or no diabetes diagnosis at all, to help bring that blood sugar down. So we're going to start talking about why are patients with type 1 diabetes usually of a slim build. So hopefully, if you remember the foundations of what type 1 diabetes is, there's an autoimmune disease which attacks the beta cells in the pancreas, which are the cells that produce insulin. So we end up with a reduction in insulin, and I like to think of insulin as a key. So insulin is the key that opens up the cells to let glucose in. So if you are thinking that we've got so insulin opens the doors to let glucose into the cells, and glucose is essentially calories, because that's how we kind of create, well, how we survive really, isn't it? We eat, we absorb glucose, and it's calories. So that if the insulin goes down, the glucose builds up, and initially the kidneys can cope and they say, I'm going to get rid of it, because they can just pump sugar into the urine and that will help get rid of the glucose. But that means we're not absorbing as many calories. So patients are going to lose weight because they're having to get their sort of calories from another source, and they're not getting it from the glucose because the glucose can't get into the cells. So by getting rid of excess glucose, you're also getting rid of calories. And eventually, if you think back to the 40s of diabetes diagnosis, so if a patient presents thin, tired, toilet, thirst, 40s, thin, tired, toilet, thirst. And if they're going to be thin because they've not got any calories, because they can't use the glucose that they're eating. So they're going to be tired as well because they can't use the glucose. So they're not fueling their body. So they're going to be tired. they're going to need to go to the toilet and have excessive thirst, because if you think back to your chemistry, if you have increased amount of sugar in the urine, water is going to follow. So they're going to keep going to the toilet because there's going to be an increased volume of urine. So that's the toilet bit. And thirst, they're going to want to replace that fluid. So they're going to have increased thirst as well. So that's the 4 T's. So if a patient ever presents to you and says, I've lost a lot of weight, I feel really tired, and I keep going to the toilet, then you should be thinking, could this be diabetes? And get them to get out. If you can test the blood sugar in a pharmacy or a GP, brilliant. If not, refer them to someone that can. So eventually we end up with patients with hyperglycemia. So you might be thinking that the kidneys are coping, and you understand why the patients become thin, because they can't absorb those calories. But when you've lost a lot of water through polyuria, so the body's desperately trying to get rid of this glucose, pumping the sugar into the urine, and the water is following. And you've got polyuria, the osmotic gradient is no longer there when you've lost lots and lots of water and there's no more to give. So because of that, the kidneys can't cope, and the glucose stops coming out of the urine, and it just stays, and that's how we end up with hyperglycemia. So if you go back to replacing this insulin with, you replace it, then you resolve this, because they're going to have enough insulin to use to unlock the cells to let the glucose in, and then they don't end up with losing weight, and they're not going to have that osmotic gradient in the kidneys and in the urine. So hopefully that makes sense as to how we end up with hyperglycemia. And something we talked about in the recording, and if you want to go back through this, I would recommend rewatching it, is the difference between hyperglycemia and diabetic ketoacidosis. So at the point when the body's not using glucose, so it gets its energy from fat instead, and a byproduct of that is ketones. And ketones are toxic, which is why we care so much about DKA. And patients can die from DKA. So we want to stop their blood sugar from going up enough that means the body's having to use fat as a energy source, and causing that ketone breakdown. And if you remember, for how we manage diabetic ketoacidosis, we're going to give a sliding scale of insulin, and we're going to give fluids, so either potassium containing fluids depending on what the potassium is, or just normal fluids to help replace that fluid loss. So back to the 4 T's, patients are going to be really thirsty, they're losing a lot of fluid, we want to replace that, and that's how we manage DKA. So on to ongoing management. So HbA1c aim for patients with type 1 diabetes and type 2 is less than 48 millimoles per litre. And we monitor that 3 to 6 monthly, because if you remember that HbA1c is a measure of the glycosylation of the hemoglobin, so how much sugar is attached to the hemoglobin. And red blood cells regenerate every 3 months, so it's a measure of 3-month control, because 3 months on from that, you'll have a whole new set of red blood cells, and that will tell you how the patient's managed for the last 3 months. We're sort of moving away a little bit from HbA1c in kind of a hospital outpatient setting, because we're looking at, because there's the new flash glucose monitoring. So I'm sure some of you, if you're in, I don't know how it works at all the hospitals, but at my hospital, pharmacy have nothing to do with the sensors. But I know in community, pharmacy dispense the sensor. So if you're working in community, you're probably likely to have seen these sensors, but if you're working in hospital, you might not have. And basically they are a disc or a sort of square, and the patient puts them under their arm, and it's a needle that stays in the skin and measures the blood sugar. And there's 2 different types. So there's the flash monitoring, where a patient must scan it. So the original Libras came with a monitor, and the newer ones you just scan with your phone. And then there's the continuous glucose monitoring, which is like a Dexcom. And you might have seen in the news that I think NICE are changing their approvals about who gets the continuous glucose monitoring. So that means the patient doesn't have to physically go with their phone and scan. It just will automatically warn them or say your blood sugar is this. So because of these new glucose monitoring, we can actually see how a patient's body is reacting to food, to insulin, rather than just having a number that sort of tells us of their control over 6 months. That number doesn't tell us how high the peaks are and how low the troughs are. It just tells us sort of the average, which is really useful information. And obviously is brilliant for diagnosing when we've not got that information. We can use the HbA1c to say, actually, HbA1c is 55. So over the last 3 months, you have got type 2 diabetes or type 1 diabetes in that instance, don't they? Whereas if we've got that sensor data, we can see that, oh, right, so on a morning, you're waking up and you're always low on a morning. Is that because you need to eat a snack before you go to bed? Or you're always high on a morning. Is that because you're not giving yourself enough background insulin? Or after a meal, your blood sugar's spiking, but then it comes back down to normal. So do you need to inject a bit earlier than your meal? So all these things that we can use to help patients manage the diabetes, because although running at high level, high blood sugar obviously is bad, and we don't want patients to be constantly high, the peaks and the troughs are bad as well. So some patients find that they go like that because they go really high, so they correct it, and then they go really low, so they eat something, and then they go really high again. So it helps us see that. But if the patient's going like that, their average is going to be here, isn't it? And that might actually be, according to the HbA1c, be okay. So it's something to think about when you're talking to patients about HbA1c. So I have a friend who has type 1 diabetes, and her HbA1c was 49. And the hospital looked at her sensor data and said, you're having way too many hypos, which is the low blood sugar, which is less than 4. If you remember, 4 is the floor. And they said to her, you need to loosen your control, because she was trying to be between 4 and 6 all the time, because she thought that she knows, she is a pharmacist. She knows all about the macrovascular and microvascular complications of diabetes, doesn't want to be going high. So was trying to control it too tightly and kept having hypos. And eventually they said, right, your hypos are damaging you as well, especially if it goes below 3. So she relaxed her control. HbA1c came up to 53, 54, and a GP rang her and said, well, your HbA1c's come up, your control's not as good. And but that is true, but that was also intentional, because they looked at the data from the sensor. So just think about how you're going to word it when you speak to patients and see what reaction they give you, because the way they went in with her was, your HbA1c's gone up, your control's got bad. Whereas she was like, actually, that's intentional, and I'm pleased it's gone up, because that means that the average of my blood sugar is a bit higher, so I've loosened my control successfully. Does that make sense? So I've waffled on about HbA1c for ages, but I do feel quite passionately about the language we use when we're discussing with patients, and to make sure that they're happy, that the patient understands that HbA1c is not the be all and end all. But also, if a patient's HbA1c is 80 and they've reduced it to 65, then brilliant. Like, that's another thing, that's a measurable thing for a patient to know that they've reduced the HbA1c by 15 millimoles per litre, which is also really useful. So it has its place, but I think we're sort of moving, in type 1 diabetes especially, moving towards using sensor data. So I'll stop talking about HbA1c now. So insulin is indicated for all patients with type 1 diabetes, and the regimes are as follows. So we've got basal bolus, which is intermediate or short-acting insulin. And if we think back to kind of our graph, so let me try and draw on this page. Pen. So if you think this is the graph, and can you see the graph? I've never done this before, but I think it's easier to explain this way. Is anyone still awake?
Can see it.
Great, you can see it. Brilliant. Thank you. Right. So if you think back, you use a long-acting insulin. If this is 0 and this is the long-acting insulin, that's going to give the kind of background, and obviously it's going to have slight waves as you inject. And then you use the intermediate or short-acting insulin, the short-acting insulin. Let me change the color, to kind of give peaks like this. So if you eat at this point and then you give yourself a peak here, and then you eat here and you inject here and you're going back up. You see, so that's naturally mimicking the pancreas in the best way. Whereas a biphasic regime, so in this instance, let me see if we can undo what we've just done. Erase all link on slide. So if we think back to a biphasic, then we've got, we're gonna, so if you think about mixed insulin, if you remember that, for example, Humulin M3, The 3 means that 30% is short acting and 70% is intermediate acting. So when you inject at this point, you're going to get a peak, but you're also going to get a peak of the intermediate acting insulin, which is going to act longer. So that's what you're looking like when you're giving the biphasic. And then you give another dose and you have the intermediate acting kind of coming in again, but at a lesser point. And so you're getting a longer coverage by doing that. The problem with biphasic regimes is that patients have to eat a certain amount. So if a patient suddenly at this point says, or kind of at this point is saying, I'm not hungry, well, you've already injected and you've already kind of committed to that much insulin for however long that's going to last. So you've got to think it doesn't work for everyone. And obviously it doesn't give patients control. So if they suddenly say, actually, I don't want to eat anything today, I'm not in the mood, they have to because they've injected. And it tends to be used for patients who haven't got that ability to use the basal bolus, because for basal bolus, you need to be able to carb count, you need to be able to assess what you're eating in good time to be able to manage it. So it doesn't work for everyone. But that's kind of the option is biphasic. And then the other option is an insulin pump, which is where you're constantly having a short acting insulin. I'm not going to draw it this time because it's kind of constant. And then they program how much they've eaten and it goes up the amount of short acting insulin that the pump releases. So if you're dispensing vials in community, it's often for an insulin pump. The new technology for insulin pumps, there's been quite recent in the last few weeks in the news to say that they've come up with a way of linking the sensor and linking the pump. So it'll all hopefully eventually just become automatic, and it's basically an artificial pancreas, because the insulin pump will react to what the sensor is saying, and the sensor will say, right, the blood sugar's gone up, and the insulin pump will release insulin. So that's kind of the way it's going. So at the moment, the gold standard is to give a basal bolus regimen. And usually that's a BD insulin detamere and a rapid acting analog. So for example, Levemir and Novorapid. And the second choice would be to give a twice daily biphasic administration. And the third choice is the insulin pump. So I've seen children with it before who have continued it into adulthood, but it's quite difficult to get one as an adult. You have to do quite a lot of courses. So you have to go on the Daphne course, you have to go on various different things to get an insulin pump, and you have to meet certain criteria, for example, HbA1c that's 69, or having disabling hypoglycemia. And that's when you're being admitted to hospital and you can't treat the hypo yourself. So that's when we would consider an insulin pump. So I've got a table here. In the recording, one of the things I suggested you did was you looked at the examples and you came up with the brand name. So what I'd like you to do in the chat is if you can put in an example of a rapid acting insulin, so insulin with its kind of name, and then the brand that is associated with, if you know. If not, don't worry, we'll go through it. So if you could put in the chat the insulin, kind of the name of the insulin, and then the brand name that is, because for me, I remember the brand names quite easily, because that's what a patient will call it. They'll say, oh yeah, I'm on 2GO and Humalog, or they'll say, oh, I'm on Humulin M3. But thinking about what that actually is in terms of the insulin name, the GPHC will expect you to know that. So if you could pop that in the chat. If you don't know, we can go through it. But this is definitely something that you need to be covering in your revision. Fine, cool. So we'll do one example. She says confidently. I don't know how to get rid of the pen. Laser pointer. Ooh, don't want that. There we go. Right, so the examples would be insulin Lispro, insulin Aspart, and insulin glulisine. So insulin Lispro is Humalog, insulin Aspart is Novorapid, and insulin glulisine is Apidra. So for some of them, there's more than one brand name. So this is just the example, and the one that you'll see most often, well, that I see most often anyway. So my trust rapid acting insulin of choice is Humalog, but obviously if patients are admitted on Novorapid, we will continue it. Apidra is not one I've ever actually seen. You guys might have, but it's not one I've seen. Short acting insulin, so it lasts 30 to 60 minutes to come on, and then it lasts for 8 hours. So that would be a human soluble insulin, which is Humulin S. We've got an intermediate acting insulin, which lasts 1 to 2 hours, and duration of action is 18 hours. And that's an isophane insulin, and that's Humulin I, or another branded insulatard. So that's those funny pen dial things. I don't know if you've seen them. I've only ever dispensed them once or twice, but they're like it's like a rectangle with a dial on, and I don't quite know how patients take it, but that's the insulatard. And then a long-acting insulin. So it takes 1.5 hours to come on, and it can last for 24 hours. So that would be insulin glargine, insulin detamere, so that's Lantus or Levemir. Does that make sense? I hope it does.
Yeah.
Cool, thank you. Right, so we're going to talk about ongoing management now. So this is a mammoth slide, and it's going to talk about the 10 processes of care, and it should hopefully be reiterating and just jogging your memory for what we've covered before. So what ongoing monitoring is there? What antiplatelets, if any, do they need, and what statins do they need? So the 10 processes of care. So if you remember from the video, I talked about how there is 9 processes of care, but we've added in a 10th specifically for type 1 diabetes. So these processes of care are for both type 2 and type 1, apart from the last one, which is just type 1. So to start off with, we've got weight. So we need to monitor patients' weight so this is every year at a minimum. Because if they are gaining weight, then that means they're at increased risk of macrovascular complications, and their diabetes is not well controlled. We need to explore lifestyle with them. They're not, insulin does cause weight gain. It is a side effect. So something to discuss with patients, as well as if their weight is going down, then that might be a sign that they're not injecting insulin. So if you think back to that first slide where we talked about the 4 T's, and we've got thin, toilet, thirst, and tired. Thin, if they're losing weight, maybe they're not injecting their insulin. And I don't know how common it is, but you do see documentaries about it and things when patients, especially when they're younger, are conscious about the way they look, and obviously if they're injecting insulin, it makes them gain weight. So they might say, well, if I don't inject, then I don't gain weight and I lose weight. So there's a psychological element there, isn't there, which is hard for young patients with type 1, hard for everyone, but hard for young patients in particular with type 1 diabetes. So it's something to think about when we're weighing patients. We need to do the blood pressure, and that's because we want to know what the blood pressure is. Do they need to be on any treatment? And we'll talk about urinary albumin and creatinine as well in this while we're here with the blood pressure. So the targets were updated in August 22 for blood pressure. So if a patient has an albumin creatinine ratio of less than 70, we want a clinic systolic blood pressure of less than 140/90. So if their ACR is less than 70, then that means they've not got chronic kidney disease. But if the ACR is over 70, then we're looking at a blood pressure of less than 130/80 in clinic, because that means that they've got that chronic kidney disease. They've already got those microvascular complications. And obviously that naturally happens as we get older as well. Kidney function gets worse. But that's why we want to measure the blood pressure and the urinary albumin and the creatinine, because we're looking at this albumin creatinine ratio, and that influences the blood pressure. So I'll say that again. If the albumin creatinine ratio is less than 70, blood pressure target is less than 140/90. And if the ACR, which is the albumin creatinine ratio, is over 70, then the blood pressure target is less than 130/80. In any patient who's 80 or more, whatever the ACR, we're going to aim for a clinic blood pressure of less than 150/90, because the risk of falls is greater than the risk of kind of microvascular complication. If you guys attended the respiratory session, you know I bang on a lot about smoking status. And if smoking, again, we're increasing the cardiovascular risk. So we should reinforce smoking cessation messages annually for patients who currently do not plan to stop smoking, and at all clinical contacts if there is a prospect of the patient stopping. And if you think back to the cycle of change, patients might be pre-contemplation, but we can move them into the contemplation zone. And most patients who smoke know the risk. They know it's obviously all over the packet. Smoking increases cancer, smoking increases risk of heart attacks. and they choose to do it regardless. So that is a decision that we can't force upon patients, but we should be encouraging them to stop smoking when we can. HbA1c, as we talked about earlier, I'm not going to mention it again, less than 48 is the target, but we do use the continuous glucose monitoring as well now. Urinary albumin and creatinine we've talked about. Cholesterol. So cholesterol is helping us identify that cardiovascular risk, and that's what we're looking for. And we'll talk about statins in a bit. Eye screening. So they should have the eye screened every year to check for retinopathy, sorry. And that's just kind of how it's done every year, and patients have to have that. And then we're going to do a foot check. So we should do foot checks whenever we can, really, because it's not something that it's quite straightforward to do. They use a 10 gauge monofilament, and they basically push it against the foot and say, can you feel that? And diabetic foot ulcers can be very difficult to treat and worsened if patients don't realise they've got ulcer or damage to their foot, and they'll continue to work on it. And it is one of the biggest complications of diabetes. So we should do a foot check to make sure that they haven't got neuropathy all the time, every time we can. And thyroid disease, that's the one that's specific to type 1 diabetes. So because the patients have an autoimmune condition, that puts them at an greater risk of another autoimmune condition. So we should check their thyroids as well. So hopefully you remember, what do we use? Hang on, let's just do this next bit first. So the ones in red are the ones we use if, so points highlighted in red are only required for patients above 12. So we don't check blood pressure, urinary albumin, creatinine, cholesterol, eyes and feet in patients who are less than 12, but we do check weight, smoking status, HbA1c and thyroid disease. So hopefully that, but obviously the weight's going to go up naturally because they're growing, but we want to keep an eye on the percentile that they're tracking. So if you could put in the chat, do patients with diabetes as a standard get an antiplatelet? You've got 50.
Can you repeat the question again, please?
Yeah, that's fine. So do patients who have type 1 diabetes or type 2 diabetes get an antiplatelet as standard? So does everyone with diabetes get an antiplatelet drug? No. Brilliant. Fantastic. Great. So they don't, unless it's for type secondary prevention, exactly. And then what about statin? So we don't use Q risk. Instead, if they are older than 40 or they've had type 1 diabetes for over 10 years, if they've got nephropathy or they've got other cardiovascular risk, so that could be kind of the cholesterol level that we're doing every year, we should offer them 20 milligrams of atorvastatin. And it's something that you don't see really with patients who have, if they are less than 40 with type 1 diabetes, but some of them have had it for over 10 years. So let's say they were diagnosed at 12. At 22, according to this, we should be considering to offer them a statin. And for some patients, they might need it because they've got high cholesterol or they're overweight and they smoke. You know, that might be a point when we're thinking, yeah, we want to offer it. But not everybody does. So it's kind of a consider rather than you must offer it. And in conjunction with the patient, what do they want? Brill. So the next slide, she says, there we go. I'm going to cover the type 2 diabetes slides again for the treatment. So we've sort of touched on we've done type 1. So we're giving insulin for type 1, easy peasy. Type 2, we're going to do a metformin. So remember, it's split between cardiovascular risk and non-cardiovascular risk. So this one is for patients with no cardiovascular risk. And in the next slide, we'll talk about what cardiovascular risk is. So first line, we're offering metformin. It's cheap as chips, it works on most people, and that tends to be what we give people first line. And if metformin is contraindicated or not tolerated, then we can give any of the others that are on the page. So sulfonylurea, gliptin, pioglitazone, or SGLT2. So the second line treatment is when we're adding in 2 drugs, and we can combine metformin with any from the previous step, or combining any of the other 2 agents apart from an SGLT2. And again, that's because there's just not that, NICE just didn't look at it. And we can come back to the third line treatment. So at this point where we've tried to, so remember at every check, every step, we should be checking adherence, we should be checking how they're getting on with the medication, is there anything that they don't like about it, to be sure that they're definitely taking the medication, because we don't want to start a new one if they're not even taking what they've got. And then third line, we should be combining metformin with any two others from the previous step, or we can consider insulin. So some patients will kind of think, well, insulin's where I'm ending up, or you might think they're really struggling with the tablets, they're not getting on with it. But you've also got to remember that insulin therapy is not particularly pleasant for patients. They've got to inject, it's a needle. And another thing we've got to think about is, as patients get older, are they going to be able to do it themselves? It's quite a dexterous task putting on a needle to a pen or checking the blood sugar, pricking the finger, screwing a needle on a pen, taking the cap off, putting the needle, it's quite tricky. So some patients require district nurses. So is that going to influence, if they're on a twice daily insulin and they need 2 twice a day district nurses, then that influences the lives, it's NHS resources. So we're going to stick with tablets as much as we can, but we might end up with patients on insulin therapy. And then that would kind of be when we'd be thinking about referring to secondary care. And fourth line is when we are going for 3 drugs or other options. So if the BMI is over 35 and they've got an obesity problem, or if their insulin is unsuitable, so for example, as we've said, they can't do it themselves and they don't want to be at home having to wait for a district nurse, then we can consider giving a metformin, a sulfonylurea, and a GLP-1 mimetic. So if you, but to stay on that regime, they've got to have lost 3% of their initial body weight at 6 months. So across 6 months, they need to have a reduction of HbA1c of at least 11, and they need to have lost 3% of their weight, of their body weight. So it's quite a tricky thing to stay on a GLP-1 mimetic, because it doesn't do everything. It doesn't do it for the patient. They're still going to have to exercise, and if you explain that to the patient, then hopefully they'll be able to do it. But they need to lose 3% of the body weight and have a reduction in HbA1c of at least 11 millimoles per litre. Or we can consider metformin, a DPP-4, and ertugliflozin. But that's only if the disease is uncontrolled with metformin and a DPP-4 inhibitor. And they can't have a sulfonylurea or pioglitazone, sorry. Or we can consider insulin therapy. So somebody's just asked me, when would we say insulin is unsuitable for a person? So I think we would say insulin is unsuitable if we're concerned about hypos. So they can't manage a hypo themselves. So for example, I don't know, this isn't on the guidelines, this is just when I would say it's unsuitable, and there will be something somewhere that says exactly when. But if a patient can't manage a hypo or can't recognize a hypo, then that's obviously a concern, because if they don't fix the hypo, then they're going to go into a coma, essentially. So if they can't manage a hypo, so for example, if they're kind of bed bound, they're not able to, so no one's looking after them, there's not somebody there that can say to that they can say to, I'm hypo. Or if we'd say they're unsuitable for insulin if they can't manage the injections themselves, and they're going to need a regime that is not suitable for district nurses. So for example, a district nurse cannot do a basal bolus regime, but eventually we're going to get to the point where they have to have insulin. And I know at my trust we have a scheme, I think it's called like 2 minutes for insulin or something. It's got a catchy name, can't quite remember it off the top of my head, but it's basically for patients who cannot cope with multiple daily injections, and they give them a super long acting insulin like 2JO, and they just do it once a day, because if obviously they've got type 1 diabetes, they need insulin, and for type 2 diabetes, eventually patients may get to that point. So that's when we would say that they're not suitable for insulin, is if they can't do it themselves and they can manage on orals, but eventually they might end up having to have insulin. So the next slide is about cardiovascular, and basing this upon cardiovascular risk. So In this instance, we assess cardiovascular status as if the patient has chronic heart failure or established atherosclerotic disease, then we add in straight away an SGLT2 inhibitor. So we start them on metformin, we establish them on metformin, and then we add in the SGLT2. And the reason we do the metformin first is just to check the tolerability, because if we start both, we're not going to know which one it is that they're not getting on with. So we start them on metformin and we add in the SGLT2. We can consider it if they have a Q risk of greater than 10. So I know we said we don't use Q risk. Sorry, excuse me. We said they don't use Q risk, but if they've got at diagnosis, if they have Q risk or they're at increased risk of developing cardiovascular disease. So for example, they smoke and they're overweight, then we can consider an SGLT2, but again, I'll discuss it with the patient. And if in any instance they develop cardiovascular disease, so for example, let's say patient has type 2 diabetes, is on metformin, and has an MI and is suddenly in hospital, then not straight away, but we should be thinking about adding an SGLT2 inhibitor. So for instance, I know at my trust we're in a part of a trial to look at SGLT2s post myocardial infarction anyway, but it's something to think about is if they're coming back to you in community after they've had a myocardial infarction and they've got type 2 diabetes, we should be thinking about an SGLT2. So the second line is we should be adding in an SGLT2, and if they're already on it, then we'll move to third, and then at that point we're the same. So the big difference is we want to start them on an SGLT2 straight away. So moving away from diabetes, we're going to talk about thyroid disease briefly. So the thyroid gland is based at the base of the neck and produces the vital metabolic hormones T3 and T4 after receiving from signals from the pituitary gland. So the pituitary gland releases TSH, which acts at the thyroid gland, which releases T4 and T3. When they're released, obviously the levels go up, and that indicates to the hypothalamus that we need less T4 and T3 because it's just been released. So that leads, that releases TRH, which is thyrotropin releasing hormone, which acts at the pituitary. So this is a negative feedback loop. So as this T4 and T3 go down, this increases, and as this goes up, this decreases, which leads to increase or decrease of the other ones. So can anyone give me an example in the chat of a positive feedback loop? Does anyone know of a positive feedback loop in the chat? Labor, yeah, brilliant. Oxytocin. So as more oxytocin is released, as oxytocin is released and level goes up, more is released. Right, so low TSH, which is this one here, is high T3 and T4. And we've got this table here that says if TSH is high and the T4 and T3 are normal, then we've got mild subclinical hypothyroidism. So because the TSH is high, so this is having to release extra to react to the thyroid to get a normal T3 and T4, then we've got subclinical hypothyroidism. And if we've got a high TSH and a low T4 and T3, then we've got hypothyroidism, which is not subclinical, it's clinical. We've not got enough T3 and T4. If the TSH is low, but the T4 and the T3 are normal, then it's hyperthyroidism, because the TSH is low. So it's saying to the thyroid, stop releasing T4 and T3. You don't need to give any more away, but it still is high, then that's hyperthyroidism. And if it's all low, it tends to be a non-thyroidal illness, but rarely it can be due to what's happening at the pituitary, rather than to do with the thyroid. So the hyperthyroidism signs and symptoms. So we've got nervousness, anxiety and irritability, hyperactivity, mood swings, difficulty sleeping, tired, diarrhea, persistent thirst, palpitations, sweating, hair loss, weight loss. And hypothyroidism is the opposite, but still tiredness. So weight gain, depression, muscle aches and weaknesses, muscle cramps, brittle hair and nails, irregular periods. It's hypothyroidism. So we've got a multiple choice question for you to have a go at now. So hopefully it's drawing on what you've learned from today's session a little bit, and also what we covered in the teaching that was online. So Mr. L has type 2 diabetes and is admitted to hospital with neutropenic sepsis and the swallowing problems. He started on a variable rate insulin infusion as he is nil by mouth until he is assessed by the speech and language therapy team. His home medication is as follows, and I'll put up a poll for you to answer. She says. Okay. Okay. So mouse keeps disappearing. So the options we've got, so there is on carbimazole, he's on dapagliflozin, which is an SGLT2 inhibitor. We've got Humulin M3, quick pen, 18 units in the morning, 10 units with tea. We've got atorvastatin 20. So which of these is the least appropriate option? So which of these is the least appropriate? We've got stop the carbimazole, start tazocin, report to the MHRA, omit the Humulin M3, or continue dapagliflozin. So which of these is the least appropriate? And if you're answering, so a few of you have already answered, I want you to think about why you've put that and think about why. So if it's the least appropriate, you're saying that you would do the others. So you want to be sure that you would do the others. And I'll just give you another few seconds to have a go at this. So which of these is the least appropriate? So you should be thinking about your MHRA alerts, what you know about sepsis, what you know about sliding scale insulin. I'll just give you 5 more seconds. Okay. So we've got a bit of a mixture here. So one person said C, 2 people said D, and 3 people said E. And the correct answer is E, continued dapagliflozin. So if we go back to the question, he's been admitted with neutropenic sepsis. And we should know that there's an MHRA alert about carbimazole that says that neutropenia and agranulocytosis is a risk of carbimazole, and we should stop the carbimazole if the patient suffers from neutropenia. So that's neutropenic sepsis, means the patient has got sepsis and they've got no white blood cells to count it, to fight it. So they've got neutropenia. So we would stop the carbimazole, which you all said, brilliant. We're going to start tazocin. He's got no known drug allergies. I don't know if I put that on there. He has no known drug allergies, and we got that right. And that's in the NICE guidelines. And if you remember, there's sepsis 6. So there's 6 things that we should do if patients we think they've got sepsis. So that's give them oxygen, take blood cultures, give them antibiotics, give them fluids, and take lactate measurements and monitor the urine output. And that should be instituted within 1 hour of admission to hospital or presentation with sepsis. And that sepsis 6 has been shown to reduce the relative risk of death by 46.6% when delivered to patients within an hour. So I'll say them again: oxygen, cultures, antibiotics, fluid, lactate measurement, and urine output monitoring. So we want to give them oxygen to help kind of with their oxygen levels. We're going to culture so that we know what bug is causing it. But if we should give antibiotics, we should culture before if we can. But if it's going to cause a delay to giving antibiotics, we shouldn't do that. We should give antibiotics because it's most important for the patient to be treated. The third one was antibiotics. Give them fluid. So we want to help resuscitate them with the fluid. Measuring lactate, because lactate is a measure of how unwell a patient is, basically. So we want to make sure that they're not going lactic acidosis. And monitor the urine output to make sure they're not in AKI. And in the NICE guidelines, we give tazocin if a patient's not pen allergic first line. So a few of you said C as the least appropriate option. So we should report this to the MHRA because it's a serious event. So a serious event is something that is fatal, life-threatening, if it causes a congenital abnormality, if it's disabling or incapacitating, or it results in hospitalization. And in this instance, we've resulted in hospitalization, so we should report this to the MHRA. You don't have to be sure that it's caused by the carbimazole, but obviously there is a known interaction there, isn't there? There's a known cause and effect, so we should report it. A few of you said that you wouldn't omit the Humulin M3. And the reason that we do omit Humulin M3 is because he's on a variable rate insulin infusion. So he's getting all the insulin he needs through that, and we shouldn't be giving him human M3, because if you remember that M3 means that 30% is rapid acting, and we don't want to give him more rapid acting insulin when he's getting it from his variable rate infusion. So we would omit human M3, and we would stop dapagliflozin, and that's because of the risk of diabetic ketoacidosis. So when patients are unwell, we always omit an SGLT2 inhibitor because of the risk of euglycemic DKA, which means that the blood sugar is normal, but the ketones are up. So essentially, when someone's admitted to hospital, we hold dapagliflozin, and patients should be advised if they're unwell at home that that's one to omit. So the answer is to continue dapagliflozin, because that is the least appropriate course of action. So that's just a bit of a case, sort of quite a tricky question in terms of there's a lot going on, but it's something that could happen, and we should stop dapagliflozin. So a bit of additional information about thyroid disease. T4 is preferred over T3 because T3 is absorbed from the intestine very rapidly, and this might cause mild thyroid hormone toxicity in some patients, and it's not recommended by NICE because T4 is converted into T3 anyway. I've only ever seen liothyronine given IV, and that's been on an endocrine consultant's advice, and we don't really keep it in my hospital. We keep a few doses. So it's not something you see that often, and that's why it's not recommended. Beta blockers are often used in the management of thyroid toxicosis, so that's to help manage those palpitation side effects. And we should monitor TFTs with lithium and amiodarone. So one of their obviously high-risk drugs, you should know about the other things you need to monitor for them. And we're not going to go through them now because we've not got time, but it's something you need to be aware of. Is the other things that need monitoring for lithium and amiodarone, but TFTs are relevant today. Levothyroxine requirement may increase during pregnancy. And Graves' disease, which is an autoimmune disease, is one of the main diseases that causes hyperthyroidism. So if you Google Graves' disease, you can see patients with enlarged eyes, and that's a sign of Graves' disease. And the reason I didn't give you this slide before was because this tells you the MHRA alerts about carbimazole. So if it's easy to remember, carbimazole, not always perfect. So we've got C for congenital malformations, N for neutropenia, A for agranulocytosis, and P for pancreatitis. So they're the 4 MHRA alerts about carbimazole. And on the previous slide, he'd got neutropenia, which is why I didn't give it you before. So that's the end of the kind of our slides. Let me just go back to the chat and see if we've got any other questions. Somebody did ask something about block and replace regimen, but I've lost it. Oh, my mouse is really playing. There we go. When do you give the block and replace regimen? Do you mean versus when you would just block the thyroid? Yes. Okay, so I think obviously it's if you're not replacing, if you're just blocking, you've obviously got to get the right amount of blocking done. Whereas if you block, you're just blocking it and then replacing the thyroid naturally. I think it would be a patient by patient basis. Off the top of my head, I don't know the exact when you give block and when you give replace, when you block and replace, and when you just block. But I suspect it's an endocrine consultant decision. It would be something that I would be looking up. But if an endocrine consultant had decided whichever one, then we would be going down that route. I know it doesn't really answer your question. I don't think I'd be very surprised if they asked you, should you give block and replace or should you give normal? Like it's quite a niche thing really, isn't it? I'm just having a look in the, so about Graves' disease, it says, and this is in the BNF, it says offer carbimazole as a 12 to 18 month course using either a block and replace or a titration regimen. So that doesn't tell you which one to use. So I think it would be a consultant decision. Jessica said, what does obesity trauma mean? In what sense? Did I say that earlier?
Yeah, I heard it, so I was like wondering what it meant, or maybe it's a mistake or something.
in terms of obesity trauma, don't think I said that. I didn't mean to if I did. What slide was it on?
I think it's when you were talking about diabetes. I've forgotten what specific slide it was.
I don't think, I think that's an error. I don't think, if I said that, I didn't mean it. I'm sorry.
That's fine, that's fine.
So off the top of my head, I don't think I said that. I don't know what I meant if I said that. I talked about obesity quite a lot. So I don't think I meant, sorry, about obesity trauma. Someone else said, just wanted to confirm if the patient was on a long-acting insulin, you would still continue that if they're on a variable rate. So at my trust, if they're a type 1 diabetes patient, we continue the long-acting insulin. But if they're a type 2 patient, we give them 80% of the long-acting dose. So it depends on your trust guidelines. But yes, you would in some form continue the long-acting insulin. But it's because we stop the mix because it's got that element of short-acting in it. Great. So just to round off, she says, I must change the slide. Ooh, hang on, I think I've just missed. My laptop's having a moment, sorry. Oh no, we are at that one. Okay. So you have now completed the endocrine session. Brilliant, well done. The next one is on blood nutrition and MSK, and that will be available. I don't know if it's already available on the website, but it will be available soon if not, and then there'll be a drop-in session for that as well. And as I've said, don't forget Instagram, Facebook and Twitter, and the WhatsApp group as well. If anyone's got any other questions, I'll hang around for a couple of minutes, but thank you so much for attending today. I hope it's been useful, and see you at the next one. I can see you popping up in the chat, but I can't see it.